Part 2 of the pneumonia lecture are ventilator-associated pneumonia and hospital-acquired pneumonia. This table shows us the microbiologic causes of ventilator-associated pneumonia. You have the non-MDR pathogen versus the MDR pathogens. So when you say MDR, it's multi-drug resistant. So non-MDR pathogens are as follows. So Streptococcus pneumonia, the most common. Other strep species, Haemophilus influenza, methicillin-sensitive Staphylococcus aureus, antibiotic-sensitive Enterobacteriaceae. For the MDR pathogen, the most common is Pseudomonas aeruginosa, followed by methicillin-resistant Staphylococcus aureus, Acinetobacter species, antibiotic-resistant Enterobacteriaceae, Legionella, Burkholderia, and Aspergillus species. On the average, 10% of ICU patients will have ventilator-associated pneumonia. There are three factors which are critical in the pathogenesis of VAP. First is colonization of the oropharynx with pathogenic microorganism. Eventually, aspiration of these organisms from the oropharynx with a compromised normal host defense mechanisms. The greatest risk factor is exposure to antibiotics, followed by cross-infection from other infected patients or contaminated equipment, and of course, malnutrition. Here's a table of the pathogenic mechanisms and corresponding prevention strategies for ventilator-associated pneumonia. So for example, large volume aspiration. Okay, so the prevention strategy is in endotracheal intubation, a rapid sequence intubation technique, avoidance of sedation, and decompression of small bowel obstruction. So this is to prevent large volume aspiration. In cases of altered lower respiratory host defenses, there should be a tight glycemic control and you should lower the hemoglobin transfusion threshold. In cases of oropharyngeal colonization, such as in elimination of the normal flora, the strategy should be avoidance of prolonged antibiotic courses. Okay, so this table shows us the pathogenic mechanisms and how to prevent these cases. So in ventilator-associated pneumonia, the clinical manifestations are fever, leukocytosis with increase in respiratory secretions. So on physical examination, you will find PE findings of pulmonary consolidation. So as to percussion and auscultation. On chest radiograph, you may find a new or changing radiographic infiltrate. And of course, other clinical features are tachypnea or increased respiratory rate, tachycardia or increased cardiac rate, a worsening oxygenation, and an increased minute ventilation. For the diagnosis of VAP, you can have a quantitative culture approach versus a clinical approach. So for quantitative culture approach, discrimination between colonization and true infection through determination of the bacterial burden. So the more distal in the respiratory tree, the diagnostic sampling, the more specific the results are. So additional tests that you may request are gram staining, differential cell count, staining for intracellular organisms, detection of local protein levels elevated in response to infection. So what about clinical approach? So tracheal aspirates generally yield at least twice as many potential pathogens as quantitative cultures. So the absence of bacteria in gram-stained endotracheal aspirate makes pneumonia an unlikely cause of fever or pulmonary infiltrates. So heightened awareness of the alternative diagnosis possible in patients with suspected VAP. And in the absence of an MDR pathogen in cultures, okay, this eliminates the need for MDR coverage, so allowing only empiric antibiotic therapy to be de-escalated. So VAP could be treated with the same antibiotics used for severe CAP. And antibiotic selection pressure leads involvement of multi-drug resistant pathogen. So drug-resistant isolates of common pathogen, you have MRSA, Enterobacteriaceae. So this producing extended spectrum beta-lactamases or gabapenemases, intrinsically resistant pathogen such as Pseudomonas aeruginosa and Acetobacter species. So the frequent use of beta-lactam drugs such as cephalosporins is a major risk factor for infection with MRSA and extended spectrum beta-lactamase positive strains. Also, Pseudomonas aeruginosa has the ability to develop resistance to all routinely used antibiotics. So here is a table of empiric antibiotic treatment for HAP and for VAP. For cases with no risk factors for resistant gram-negative pathogen, okay, but your options are piperacillin, tazobactam, cefepime, and levofloxacin. Whereas for cases with risk factors for resistant gram-negative pathogen, you choose one from each column. So you can have piperacillin, tazobactam, cefepime, ceftazidime, imipenem, meropenem, plus any one of this from this column. If the case has a risk factor for MRSA, you can add the following drugs, so linezolid or vancomycin. So once the etiologic diagnosis is made, a broad-spectrum empirical therapy can be modified to specifically address the known pathogen. A negative tracheal aspirate culture or growth below the threshold, then antibiotics should be discontinued or that a search for other alternative diagnoses should be pursued. Usually, a 7 to 8 day course of therapy is effective, okay, versus a 2-week course, and is usually associated with less frequent emergence of antibiotic resistant strain. So whenever possible, just give a 7 to 8 day course of antibiotic therapy. Recurrent ventilator associated pneumonia caused by the same pathogen is possible because the biofilm on endotracheal tubes allows reintroduction of the microorganism. How about complications? So you have death, prolonged mechanical ventilatory support, increased hospital stay, especially in the ICU, catabolic state in a patient who is already nutritionally at risk. And for follow-up, so clinical improvement should be evident within 48 to 72 hours of initiation of antimicrobial treatment. Chest X-ray is less helpful than clinical criteria as indicator of clinical response. So crude mortality rates are as high as 50 to 70% for ventilator-associated pneumonia. And MDR pathogens contribute highly to the mortality than non-MDR pathogen. So how to prevent VAP? The most important preventive intervention is avoid intubation or minimize duration. So minimizing microaspiration around the endotracheal tube cuff. Okay, and elevating the head of the bed to at least 30 degrees above horizontal, but preferably 45 degrees. So this decreases VAP rates. Now let's go to hospital-acquired pneumonia. So we define it as pneumonia occurring 48 hours or more after admission to the hospital. Severe hospital-acquired pneumonia is defined by the concomitant occurrence of sepsis syndrome, respiratory failure, rapid progression of radiographic shadows, multilobar involvement, or cavity formation. So there is a higher frequency of non-MDR pathogens than VAP, and lower frequency of MDR pathogen allows monotherapy for HAP. So the greater risk of macroaspiration by non-intubated patients and lower oxygen tension in the lower respiratory tract, okay, poses anaerobes as the etiologic agent. So as in the management of community-acquired pneumonia, specific therapy targeting anaerobes probably is not needed since many of the recommended antibiotics are active against anaerobes. So this table shows us the indications for streamlining of therapy. So when you have resolution of fever for more than 24 hours, your patient now has less cough and resolution of respiratory distress. There is improving white blood cell count. The etiologic agent is not a high risk. There is no unstable comorbid condition or life-threatening complications such as myocardial infarction, congestive heart failure, a complete heart block, new atrial fibrillation, and supraventricular tachycardia. Of course, there's no sign of organ dysfunction such as hypotension, acute mental changes, hypoxemia, and metabolic acidosis. And patient is clinically hydrated, taking oral fluids, and is able to take oral medications. So here are reasons for a lack of response to treatment of pneumonia. So correct organisms are isolated, but there's inappropriate antibiotic choice or wrong dose. There is resistance of organism to the selected antibiotic. There is wrong dosage. So in a patient who is morbidly obese or has fluid overload. So antibiotics may not be able to administer. So correct organism and correct antibiotic, but infection is loculated. So probably there can be an obstruction when there is incorrect identification of causative organism. Okay. There is no identification of causative organism and empirical therapy directed toward a wrong organism. So in cases where the cause is non-infectious, in cases where fever is drug-induced, okay, and in the presence of an unrecognized concurrent infection. So here is the criteria for discharge. So during the 24 hours before discharge, the patient should have the following characteristics. Okay, so with no episode of fever, the pulse rate is normal, Respiratory rate is between 16 to 24 with a systolic blood pressure of more than 90 millimeter mercury, so there should be no hypotension, a blood oxygen saturation of more than 90%, and a functioning gastrointestinal tract. So when all of these are met, okay, you can discharge your patient. Prevention. So vaccination, vac- vaccinating your patient can prevent pneumonia. So prevention of pneumonia may be possible by administering the pneumococcal and influenza vaccines for eligible patients. So the recommendation for administration of live attenuated influenza vaccine are healthy persons from 5 to 49 years, including healthcare providers and household contacts of high-risk patients. For pneumococcal vaccine, so here are the indications. So person age more than 65. Persons with chronic illnesses, so COPD, bronchiectasis, chronic tuberculosis, as well as non-pulmonary diseases. Persons who are immunocompromised, such as those with HIV/AIDS, lymphoma, cancer patients, residents of nursing homes and other long-term care facilities, and persons aged 19 to 64 years old who are smokers or asthmatics. Okay, so a single dose given intramuscularly or subcutaneously, and a one-time revaccination may be given to the following groups. So precaution and contraindication. So immediate anaphylactic reaction to a previous dose of pneumococcal vaccine. So those who have allergy to a vaccine component. Okay, and those who have moderate to severe illness with or without a fever. What about for influenza vaccination? So all persons aged more than or equal to 50 years old with chronic illness, those with immunosuppression, pregnancy in the second or third trimester, residents of nursing homes and other chronic care facilities, healthcare personnel, household contacts, and caregivers, okay, and others. So adult dose is 0.5 ml intramuscularly once a year. So again, here are the contraindications. So anaphylactic reaction, allergy to eggs or to a vaccine component, moderate or severe acute illness, acute neurologic disorder, or a history of Guillain-Barré syndrome. Thank you.